So Sandeep, welcome.
So I've got two of my British colleagues, John Davis and Carl Tang. They're from Essex in England. So they
Hi,
are here
hi,
for
John.
the workshop. We did some cases, and they're going to join because they are the CTO experts as well.
All right. Okay, so the format is a very, fast presentation, 15 minutes, and then another 15 minutes for discussion.
Yeah, I mean, I'll go. We can always keep it. I've got a presentation. We can always chop and change.
Okay.
I need access to share
You,
my screen.
you can do it now. You should be able to do that.
Yes.
All right.
Can you see the screen?
Yes.
Oh, yes, we can see it. Yeah.
Okay, so obviously, we will get more input as we go along because I've got my colleagues here. So this is a retro PCI talk. So the objective is to go through kind of when and why to go retrograde, and sort of tips and tricks when using retrograde PCI, and of course some complications to watch out for. So the retrograde PCI, let me just try and see if I could move this. So obviously, when you actively access collateral channels to open the CTO, we call it retrograde CTO PCI. When I say actively access, which means you could use retrograde collaterals for guiding your anti-grade wire. But if you actually access it to finish the procedure, we call it retrograde CTO PCI. There's nothing called a pure anti-grade or retrograde case because I feel if you're a complete CTO operator, you have to be dynamic in that approach, and you have to ready to switch to retrograde in the same setting. Because in some centers they have some anti-grade operators where they stop and then they give it to more experienced retrograde operators. I think if you want to be a complete CTO operator, I think you have to be in a position to switch to retrograde, especially if you're not making an anti-grade progress. When to consider retrograde PCI? I think if you go through the hybrid algorithm, they have a big algorithm, but I think this is what we do, and I'm sure John and Carl, they do the same. So unable to catch the true lumen antigrade list. So for example, in this post-bypass CTO, you see we made some antigrade progress, but the wire kept going subintimal. Obviously, at this point, you can stop, or you then come from the retrograde using some of these subtle collaterals and complete the procedure using a reverse cart, which will come to that. This is a paper from 2018 on progress CTO, which kind of shows that as you go up on the JCTO, as you know, JCTO score is a scoring system which will tell you how complex the CTO is. So the higher the score, complex the CTO. So as you go into 3, 4, 5, you could see the yellow bars are the retrograde goes consistently up. Whereas if you got a JCTO score of 0 or 1, most of them can be done antigrade wire escalation, and ADR obviously will be in sort of 2 and 3. But as you go up the ladder, your retrograde number goes up. And of course, there are scenarios like this aorta ostial lesion where you don't have any antigrade channel to start the case, in which case you start going retrograde upfront. And I'll just show you this case. So this is a case of a ostial occlusion of an RCA. So in this case, you can't make any antigrade work because you don't know where the ostium is unless you've done a CT. Even with a CT, sometimes very difficult. Yeah. Any questions? Okay, maybe some.
No, go ahead. Go ahead.
So in this case, you have a retrograde, you go upfront retrograde. So these are the only two scenarios we go retrograde. But if you go with the CTO crossing algorithm with the hybrid approach, they have this algorithm where if you have an ambiguous proximal cap, a poor distal targets, good interventional collateral, then they say retrograde upfront. But we still try integrate in most of our cases. So tips and tricks for retrograde CTO PCI. I think setup is very important. So we tend to do radial femoral in our setup. So we do one radial, one femoral. But some centers like John and Carl, they use biradial in 70% of these cases.
Sorry, Rima, please mute yourself. Okay, I did it. Okay, sorry, Sandeep.
That's okay. So then some centers do bifemoral. I think bifemoral is kind of going out of fashion. We have to have at least one radial axis. And for the retrograde, we should have 7 French guide at least in both antegrade and retrograde limbs. Some places use 8 French, but I think 7 French is the least amount, because if you use 6 French, it's very difficult to exchange stuff with the microcatheters and balloons and etc. And obviously, one of the guide has to be 90 centimeters. So the normal length is 100. Obviously, if you take 90 centimeter, then you get more slack when you're externalizing the retrograde wire. I tend to use both short centimeter guide, so it gives you more slack with the retrograde kits. Always take a supporting guiding catheter, both antegrade and retrograde. So, for example, use in this case, obviously AL1 may be used. And of course, you use EBU 3.5 for the retrograde. So using AL1 gives you more support for pushing the microcatheters and other things. Collaterals, of course, you got 3 sets of collaterals. You got bypass, which is the most easiest one, where you can go through the vein graft and enter the native circulation. But most commonly used are these septal collaterals and the epicardial collaterals, which are obviously more risky, but can be accessed. This is just a grading of the different kinds of collaterals, the problems and with them. So if you look at the tortuosity, bypass graft collaterals have got very less tortuosity, whereas epicardial are the most tortuous one. Difficulty with wiring, bypass graft is very easy to wire. Epicardials are the most difficult because they're very, very fragile and very tortuous. Ischemia, probably epicardial, you'll see more ischemia because that's usually the single most collateral. But as septal, you've got quite a few. So even if you occlude, some patient may not have ischemia. So amenable for angioplasty. So for example, if you can't make any progress with the microcatheter, you can balloon the collaterals, but you should never balloon epicardial collaterals. So of course, the tamponade risk is very high with epicardial collaterals as compared to the other two. So just quickly, septal collaterals. I mean, we were discussing this morning. We all have different choices for septal collaterals.
Sandy, sorry. So since here we have colleagues that do not practice retrograde approaches so far, or they have a limited experience.
Yeah.
Wanted just you to spend 30 seconds on telling us which is your approach for the selection before the wiring, the selection of the collaterals. So, for example, you do 2 or 3 orthogonal views. For example, for the septal, you do this, you do that. How much time do you spend in selecting the right collateral? Because this can be time demanding, and setting it up very, very nicely at the beginning will render the procedure much easier. So I want to just to spend a few words on that.
Do you guys want to say something about that? Yeah, Carl will say that.
I mean, usually we get a diagnostic angio, and from the diagnostic angio, we tend to look at what's available, whether there is an antegrade approach or a retrograde approach, which is the one that we're going to go first. We look at the septals, and again, it depends on whether the person who took the diagnostic angiogram is thinking ahead that this patient may need a retrograde, may need a CTO procedure, then they may take some additional views. But in most of the case, we look at the diagnostic angio, get an idea which of these collaterals we may choose to use, whether it's as a first approach or whether it's a second approach or a third approach. And then when we set up with our certain views, which we do for dual injections, so all CTO need generally dual injections, and from that we will then position to see which is the best position for us to see the collateral and how it's going to feed through. So, for instance, if it's looking at the RCA, looking at the collateral from the LAD, a lot of them from the cranial view will give you an idea of where the collaterals come from the septal. But really, it's rather fluid. You've picked the pictures where we see the best path where the collateral goes. And you may need orthogonal views in order to, because always you may see the entry of one collateral, but you can't see the distal. You have to do a different view to see the collateral. And obviously, we'll be injecting at the time when you do the CTO as well, in order to see where the collateral ends up. and to ensure that your wire position when you're crossing it is in the right position.
All right.
I mean, the other thing I might just add there is that we tend to choose septal collaterals over epicardial collaterals because the complication risk of a septal is much less than an epicardial in terms of the tamponade risk. And I think one top tip would be to say, you're not really looking for the obvious large channels necessarily, because large channels are not necessarily any easier. I think what you're looking at is the entry angle into the septal, the exit angle out of the septal, and you're looking most critically at the straightness or tortuosity of the septal. So in an ideal world, you want to try and go for a septal where the angle from the LAD is favorable, the angle into the PD is favorable, and it's straight.
Yeah. So probably if you're doing RCS CTO, if you're doing a septal collaterals, AP cranial and RAO cranial are a very good view for seeing the whole collateral. If you're accessing an epicardial, LO cranial is the best because you see the connection of the epicardial into the maybe PLV branch generally.
Yeah.
Does it answer your question?
Guys, very quickly. Very quickly, there's a move, particularly in this sort of Asian region, towards doing like CT coronary angiograms prior to attempting the CTOs. Is that something you guys do, or do you practice that, as in doing CTCAs to map out your CTOs before you embark?
Yeah, I mean, certainly in Essex, I would estimate that perhaps around about 40 to 50% of our cases have had an upfront CT coronary angiogram. Some of those, the CT was done as a diagnostic in the first place, but quite a number of them are what we would call dedicated CTO CT coronary angiograms. And essentially, as a CTO operator, you've got to become quite proficient at being able to look at CT coronary angiograms yourself, reconstruct them yourself, and interpret them. And I think if I was to try and keep the answer as short as possible, I think the one critical thing about a CT scan is calcium. So that's really where it becomes very useful indeed, is in determining the location and extent of calcium at the proximal cap, in the body of the CTO, and at the distal cap. I think that's the most critical factor, and in fact, that's what CT was made for, really.
Yeah. I mean, look,
also in Italy, actually, we never use it up front for CTO recanalization. We use it in case of failure, if we want to understand a little bit better long CTOs calcification, but not as an upfront procedure, not yet.
Yeah, no, I mean, so we use it in, as I say, about 40 to 50%, but that tends to be in the ones that failed, for sure. The ones that have failed, most of them will have a CT scan, but also ones that have got very high JCTO scores, we tend to also go for it up front. And I think there is a little bit of evidence to suggest there in a randomized fashion that that CT does indeed improve the success rates.
Yeah. Yeah, I mean, we don't have it that often, but in failed cases, we definitely do it. Although we don't have a dedicated CTO radiologist, but we have one in Birmingham who does it. So I send it to her, and she's extremely good.
It's also very good for those with ambiguous cap, or where the branch, you're not quite sure where the original the vessel comes from, and the CT will be able to, with classification, tell you where it is. And then you can sort of look at the CT, say it's about 30 millimeters from the ostium, that's where it branches off. Then you can actually use that information for you to, be a bit more successful.
Yeah, it's particularly useful in proximal LAD CTOs. Quite often it can be quite ambiguous as to whether the cap is, flush occluded with a diagonal, or in fact whether there is a small amount of vessel that almost sometimes look like a septal, but it's not. It's the real LAD, and we've used CT on a few occasions to make that an easier spot.
So essentially, if you think it's tricky, get a CT. I think that's simple.
Yeah. Thank you.
apart from this, your retrograde guide will be would always be 6 French or 7 French?
No, 7 French. If you're using a retrograde, always go for 7 French. At least some people use 8 French, but 7 French has to be a minimum because it gives more maneuverability for exchanging kits.
Yeah, yeah.
I mean, I think you can do retrograde through 6 French, so it's not a barrier, but
Desirable.
Ideally, yeah, bilateral radials for me, 7 French is probably the ideal setup, but of course that's not always achievable. I think if we have a choice, but if we can only fit 6 French up 1 radial, then we'll probably just sacrifice 7 French and go 6 French if it means we can go bi-radial, because it takes any of the worry out of femoral complications then.
Yeah, thank you.
So the wire for septal collaterals, obviously we all have different choices. I normally go with Sion or Sion Black first, and then maybe XTR or a CO03. I tend not to use CO03 because it's very, very fragile tip and it's a very expensive wire. So sometimes if it damages, you can't use it again. So this is just an example of a septal collaterals. It's a post-bypass CTO. You could lots of collaterals for septal collaterals. Obviously, you enter with the microcatheter, so you could see the microcatheter there. You take just a workhorse wire to enter, and then you switch it to a more like a Sion or a Sion Black. So obviously here you see we've got access into the PLV branch, and that's a microcatheter. So which means now you're set up to do a reverse cut. This is another case of septal collaterals, which going with the microcatheter, and this is Sion Black. You're feeling it, and then you enter the distal arch. So you could see it here. Sometimes they call septal surfing. Sometimes you're redirecting it more intentionally, and then here. Now with the septal, sometimes you have this very like what we call as a heel bend, where it's very difficult to spin the corsair, in which case you can use something called an anchor balloon. So here you could see there is an anchor balloon in the diagonal where I've inflated, and I've asked the second operator to tug on the balloon. So they're pulling the balloon gently. So it kind of anchors your guide so nicely. So then you can spin the corsair. So you could see here the corsair is being spun very nicely, which would not be possible without this because guide kept backing out. The moment you put the anchor, you see how nicely the septal collaterals can be traversed through with the help of microcatheter. And even in the body of the CTO, you could still use an anchor to maneuver your microcatheter. But don't do this in epicardial collaterals because epicardial collaterals will perforate if you do the anchoring. So this is one of the highlights of epicardial collaterals. This is called a CO03 wire, one of the best wires we have for the retrograde, especially epicardial. It is such a soft wire, and the tip load is only 0.3 grams. So the damages are extremely rare with this wire. They are expensive, but if you're doing an epicardial collaterals, you have to have this wire. This is almost like a default these days to use this wire. So this is an example of a epicardial collaterals. You could see a LAD distal filling the RCA. And of course, you epicardial collaterals, the key is to make sure don't push on the wire too much, just a gentle traction, and it moves with the heartbeat. So this is a caravel. You see here, we're just gently putting a forward pressure, and it kind of forms a loop. Now, this is very important. You have to release this loop by pushing the microcatheter. So for example, here, you cannot push this anymore because it won't be able to maneuver. Whereas if you push the microcatheter here, it releases the loop, and then you can push more. See, I'm just pushing the microcatheter, but you should never go beyond the wire. You should stop it from the RV marginal range into the distal LAD. So always have a safety wire. This is what I always recommend. You put a safety wire in the RCA so that something happens into the epicardial. You can always balloon tamponade and then insert the coil if you want to stop the bleeding. And the most important step again here is that to make sure these loops are taken out by pushing the microcatheter so that you're releasing the wire, and then you just gently put the forward traction. You could see here we're just gently putting the forward traction, and Carr made a good point. You sometimes may have to torque, but do that, you'll be able to maneuver it. It's a safe wire, but you have to know how to do it. As I said, don't push too hard, just a gentle forward traction. And then you have to release the loop. You could see here, I'm releasing the loop by pushing the microcatheter and then making the advancement.
What is your choice of microcatheter in case of epicardial collaterals?
Very good point. So for epicardial in a non-calcified CTO, I tend to use Caravel. But if it's a calcified CTO, I tend to use Corsair, because as you come to the body of the CTO, Caravel doesn't have that push. You need to torque. So I tend to use Corsair. Corsair Pro XS is very good. It's low profile. You can use it even in epicardial. But if it's a non-calcified, I tend to use more Caravel. Is that the same for you guys?
Yeah, I mean, Caravel is always the first choice most of the time. Of course, you lose the ability to torque the Caravel microcatheter, but surprisingly, it tends to be able to cross quite a few of the ones that you didn't think it will cross. So yes, of course, Caravel first, and then Corsair if it doesn't go.
Yeah.
So never anchor when you're traversing epicardial. I think we already mentioned it. You can do that for the septal, but epicardial, we can't do it. The microcatheter, always take 150 centimeter. Never take 135 for a retrograde, because you need that extra length. So you could take Corsair Pro, Turnpike LP, or Mamba, which we don't have. Mainly we rely on Corsair Pro and Turnpike LP. For septal collaterals, for epicardial, as Kar just said, always go for Caravel or a fine cross. And then Corsair Pro or Turnpike LP, maybe in a calcified lesions. This is important. Once you're at the distal cap, what to do next? Okay, this is very important. You could either go for a retrograde wire escalation, so which means you're puncturing the distal cap and navigating the wire into the proximal cap and into the antegrade guide. If that fails, then you could go for a reverse cut, which I'll explain that. Sometimes we do deliberate knuckling, especially in a calcified lesion where you can't go through the calcium, you're going around the calcium. So retrograde wire escalation is basically like this. So this is a very, very ambiguous cap. Okay, we didn't even know where to penetrate this. So obviously in this case, we tried a little bit, but it was going into a la la land. So we then went through the septal collaterals. You could see there's a septal collateral coming in. And when we arrived at the distal cap here, the current teaching in hybrid is you can knuckle it, but not necessarily. Sometimes you can try, especially when you got a calcium to guide. So we went with the Gaia 3 here, and we obviously are in the vessel architecture, and using the multiple angle, you can just navigate your wire. You see the wire nicely going up here, and then you confirm with multiple positions. So we do LAO and RAO, your coaxial, and then you can just enter the wire directly into the antegrade guide. So here the wire is going into the antegrade guide. Once that's done, you can finish the procedure. So in this case, we didn't do any antegrade work. And this is another case. This is a LAD CTO, quite like flush occlusion from the ostium. Okay, you could see this is the LAD CTO. Obviously, we tried antegrade. We tried multiple views, parallel wire. We were unable to catch. We were very close, but we were never able to catch this parallel wire. So we went retrograde through the epicardial collateral from the RCA. You could see this is the epicardial collateral. We got into the distal cap. Once you came to the distal cap, again, you don't have to knuckle. So we went, and you could see the movement of the Caravel. We took just a Gaia 3 wire, and we were able to enter into the antegrade guide. But here you have to be extremely careful to make sure that you're entering before the left main. So you could see here the wire going into the antegrade guide. But we have to do an IVUS to make sure your proximal LAD, you're in the true lumen. And in the left main, you have to ensure you see the wire of a circumflex. Because if you see the circumflex here, which means you are subintimal. And if you stent it, you lose the circumflex. So you have to demonstrate that in the LAD CTO. So this is the final procedure result. So reverse card is basically a controlled antegrade and reverse and retrograde.
I think we lost Sandeep, is it?
Yeah.
Can you hear
Yes.
us?
I think so. Yeah, now yes. So Sandeep, we lost you when you started saying the reverse card.
Sorry. Okay, reverse card is basically a technique where you're connecting the antigrade wire, which is in a subintimal space, and the retrograde, which is in a subintimal space, by ballooning the.
Excuse me,
on
Dr.
a-
Sandeep, we can't see the presentation.
Oh, you cannot?
No.
Okay, sorry. Can you see it now?
Yes, thank you.
Thank you for pointing that out. Sorry, my mistake. I think maybe we went offline. So I'll go again. So reverse card is basically you got antigrade wire in the subintimal space and retrograde wire in a subintimal space. You're connecting the two space by ballooning. So basically you're taking a balloon on an antigrade wire, inflating the balloon, and the spaces are connected. And once they're connected, you either put a guide liner and then catch the retrograde wire and you can finish the procedure. I'll just show an example. So this is a RCS CTO. Previous vein graft has failed. You could see there's a stent in the vein graft, which is failed, which blocked. So we went antigradely. We were subintimal. So we went from the retrograde septal collaterals. And you could see here the septal collaterals come in here into the body of the RCS CTO. And so this is both the wires. You could see there's a retrograde wire, antigrade wire. They're very close. That's a good thing about the conventional reverse card where you're not knuckling, which means the wires are wide apart. So all you need is just a 2 millimeter balloon. And you could see there's a guide liner here. We've done the ballooning on here, and we were able to put the wire from the retrograde into the antigrade guide liner, and we were able to finish this procedure. So this is another case. You could see this is probably you could see it better. So this is a retrograde wire. This is an antigrade microcatheter. The wires are very close. So then you basically balloon it and bring the guide liner. I think you'll see the guide liner. So that's the guide liner coming in. Okay. So you bring the guide liner in and you inflate the balloon. And then you can take the wire. You see the wire now going into the guide liner. And once that's done, we just have to externalize the wire using an RG3, which is a specialized retrograde externalized wire to finish the procedure. Once you're in the retrograde wire, once your retrograde wire is in the antigrade guide, you have to anchor the wire with the balloon, and then you have to milk or you want to push the microcatheter into the guiding catheter before extending to RG3. So if I show you this case here, so basically there's a balloon here, which is inflated and it is catching the retrograde wire, kind of it's splinting it against the guide. And then you can push the microcatheter into the retrograde, into the antigrade. You could see the microcatheter going in there. So another case here where the wire has gone into the antigrade guide. You inflate a balloon and you milk the retrograde microcatheter. You could see that's going in here. And once you put the RG3 wire, you have to take the Y connector out, and you could see here they've externalized it. It's coming in, and you connect this. You introduce a needle, and then you see you should never pull. You have to have someone pushing from that side and someone pulling on. It's like a simultaneous movement. He's pushing the wire, and the wire comes out here. Watch the wire, and he's gently tugging. You should always push from that side. That this is important. And then you're doing it. If you're in epicardial collaterals, we try something called a tip-in, which basically what it means is that this is your retrograde wire into the antigrade guide. So this is, let's say, left main stem, circumflex LAD. Imagine you come from a retrograde channel, you come into the antigrade guide, then you take a Fielder FC wire or any kind of wire, and you put that into the retrograde microcatheter. So essentially, by doing that, you're stopping that externalization, which can have complications, especially in epicardial collaterals. So if I don't know if I displays very well. So this is basically what you can see here. If I pause this, all you see is that this is the retrograde microcatheter, which has come from the RCA all the way into the LAD, left main stem, and in the guide. And here we parked it here, and we brought a wire, which is a Fielder FC or any wire. And you see here the wire comes, and we are trying to get into the antegrade. You see here, it comes here, it comes here, it comes here, it goes here. Can you all see this?
Yeah, I've seen.
So basically, you take a wire and try and feed into the microcatheter. You can always do this in the outer side of the guide where it all comes in the same plane. You always do this?
It is a straight tip. Your wire is a straight tip, not any bend. No bend in that wire.
I don't tend to put a bend. I keep it straight. Do you do the same?
What, on the tip-in one?
Yeah.
Yeah, tipping.
No, I tend to put a little J on it, but I mean, I think the most important thing when you're tipping in is it's usually easiest on the outer curve of the receiving guide.
The guide,
so
yeah.
and it's surprising at how straightforward it often is.
Yes.
It'll normally work within a minute or so.
It's a trial,
in most cases, and I think it's a good technique, I think, as you say, for epicardial or even for some of the septal collaterals where there's a lot of tension. Some septal collaterals kind of have that sort of big curve in them as they come round and into the PD. And if you're pushing too hard,
you can
on a microcatheter to push it up into the antegrade guide, you can avulse the septum, which is a nasty complication. So, I mean, I think if you're struggling to get your retrograde microcatheter into your guide, it's much better to tip in rather than keep struggling.
I think the other where I'm really helpful is that there's ischemia from epicardial. Yeah. Patients have got ST elevation, or that is where epicardial, this tip-in helps a lot because you're then taking the strain out. And for example, you see now I'm pulling the microcatheter back. You'll see the microcatheter now all the way back, which means now I'm taking the tension out of the epicardial. I'm just going to work on my antegrade wire. So complication, I think there are, complication can happen during any CTO PCI, access guide complication, but these are the two important which happens in retrograde. One is the collateral perforation, donor guide dissection. I'll just show you this graph, again, from the trial progress CTO registry. You could see here, whenever they did the retrograde, you could see the overall complications much higher than antegrade wire escalation or ADR. You could see here perforation sky high with the retrograde. So with every complication, you can label MACE, death, acute MI, stroke is higher in the retrograde PCI. So yes, it is associated with risk, but that shouldn't shy you away from training because it is an important step in completing the CTO case. In our setup, we use 30% retrograde PCI, same in your center as well. So 70% we get through antegradly, in 30% you have to switch. So if you don't do retrograde, which means those 30 patients will not get a complete revascularization or a successful case. This is a case of a septal perforation. Okay, as John was saying, we have all the septal here. You could see a big perforation, but septal perforation are generally benign. They are forgiving. Very rarely they cause VF and things like that because of the septal hematoma. They generally are used. For example, this was done, and look what happens 2 months later. 2 months later, everything is healed. And, so this was a very forgiving. Whereas epicardial is not. So this is an epicardial collateral. So we tried antegradely, we failed. We came retrogradely, and you could see the staining here, which is from epicardial perforation. Luckily, in this case, we got away because we did a prolonged balloon tamponade. But, you could see that, the problem. And this is a donor guide dissection. So this is a LAD CTO. Okay, so we got the JR for guiding catheter for retrograde access. We got in through the septal, like PDA septal. We made some antegrade work. We got the retrograde wire. We are set up for reverse card. You could see there is an antegrade wire here. So retrograde wire here, antegrade wire. We are about to do a reverse card. Patient develop chest pain, and see what happens. The whole RCA is dissected. So she's got ST elevation, hypotension. So we had to pull everything out, stent the RCA, and luckily patient was okay. She survived. So donor or guide dissection is a very important complication. which you have to keep an eye on, especially when the guide dives in deep. So you have to always have a safety wire so that you could always put a stent in when taking everything out. So it's something to watch out for. Do I have 5 more minutes, Bernardo?
Yes, please go ahead. I had to leave, so I'm in the car, but yes, please, we have time.
Okay. So this is just one example of a case which we did in our center a few years ago. 66-year-old man with angina. He had a bypass in 2015 when he had lemur LAD and vein graft of his marginal. RCA was a CTO but was not grafted, and we're not sure why it was not grafted. Patient ongoing chest pain despite maximum medical therapy, viable inferior wall. So essentially we did the angiogram. Obviously the left system is blocked, LAD is blocked, but there's a patient lemur. And you see there's a vein graft to the circumflex, and the lemur to LAD is patent. And RCA was interesting. We could not intubate the RCA. So we could not get the RCA intubation. There is some branch here. We don't know where this is. This is probably a flush occlusion. So obviously we looked at the angiogram before the bypass. So this is before the bypass. Even then, they had struggled to intubate the RCA. So it was almost like a flush occlusion. As John said, and as Bharat, you pointed out, what next? So we did a CT. So if I place a CT very slowly. So you see the left system. So that's your left main. But as you come, you'll see a calcium here. Now, we don't know whether this is the RCA origin because you can't see in there. So obviously we put the contrast. So this is a contrast. Again, you see the left system here. And as you come, that's the RCA ostium. It's more anterior. So it's more anterior. That's your sternum. So it's more anterior. So we got to know there is an ostium. Obviously, we can't intubate. So what's the next strategy? So we went upfront retrograde. This is the classic retrograde PCI where you have to go upfront because there's a flush occlusion. Took the septal collaterals. We're lucky to get into the distal. You could see here the wire going nicely. And we got in here. We're in the distal RCA. So obviously we had to spin the, we had to put an anchor. So we put an anchor balloon in the marginal because we're unable to spin. You could see when you put the anchor balloon, the guide stays nicely firm and you get that amazing push. You could see here the retrograde microcatheter going nicely with anchor balloon. So we came to the distal cap and you could see the wire is nicely flying. This is just a Sion wire, not even a CO03. This is a Sion wire. And we got the microcatheter and we got in here and we brought the microcatheter more. And what next? So here we tried to puncture the proximal cap. So this is Gaia 3 and we got in. We went somewhere. So you could see the wire goes somewhere here. Okay. When we pushed the wire went somewhere here. You know where the wire was?
This is the very important step. What do you think? Because sometimes if we are not at the right point of the puncture at this ostial, we can puncture the aorta and come outside,
Yes.
Inside into the aorta.
So you look for aortic whip. So the wire will have free flotation with the aortic jet.
Okay.
But here, this has gone into the vein graft,
Mm-hmm.
the marginal. So we were pretty happy. So obviously now what we did was because there's a branch here, which is like the one which we saw like a conus branch, we put the wire in, we inflated a balloon, and we then anchored, and we sucked the guide. Once we sucked the guide, then we just aimed. I mean, some people do a snaring. I'm not that fond of snaring. I'll try and see if we could wire it, and you could see it. Wire goes in here. So this is the retrograde wire going into the antegrade guide here. And then you just anchor it and we ballooned it and we put a stent in. So in summary, retrograde CTO PCI will be needed in proportion of cases. Don't shy away from it. Train in retrograde CTO PCI, especially if you want to be a CTO operator. Setup is very important. We discussed that, and know your step. This is the most important. You should know the steps and troubleshoot when you have reverse card not working, what to do. You may have to move your goalpost in a different section of the RCA to connect the wires. You should know where the wires are more close to each other. That's where you should do the reverse card. Be gentle on the collaterals, especially epicardials. Don't embark epicardial collaterals, especially in the early phases of your career of retrograde. So try with the septals first and then slowly go on to the epicardial. Beware of the complications and know how to treat them. Thank you.
Thank you very
Yeah,
much.
thanks, Sandeep, for this presentation, which actually went a little bit longer, but I think that it was deserved due to the complexity of the procedure. I would like to, sorry, I cannot be very active because I'm in the car, so actually I couldn't see also the angels, but I just was able to listen to you. I wanted to ask to the fellows if there are questions. There should be many, hopefully, or other topics that you would like to know more deeply about retrograde CTO.
Yeah,
obviously we got John and Carr. They're more experienced than me in CTO PCI. So
I have one question. It's very important. This is very nice presentation. While doing the reverse card, we are doing sometime. I was on the anti-grade wire to look for the 4 morphologies of the wire. There are 4 patterns of the wire. Both are subintimal space, but one is in the intraplug, one is a subintimal. So what is its significance, and which positioning of the wire is appropriate for reverse card?
Yeah, I mean, for the reverse card, so basically, in the ideal way, you want the retrograde wire in the lumen and the antigrade wire in the lumen, and therefore they're both joined nice and easy. Or if they're in different space, so if either the antigrade or the retrograde is in the subintimal space and the other one's in the lumen, that's a difficulty, okay? If they're both in the subintimal space, then that again will be easier. So you don't know which of those categories you're going to fall into. Is it lumen and then subintimal, or lumen and lumen, or subintimal and lumen? So that's why you need to work out where you are to know how to connect the 2 wires coming back, well, one from the front, retrograde and antigrade. So having IVUS, that would tell you which was it in subintimal or is it not. Obviously, you can only pass the IVUS down the antigrade wire, and it would tell you where your antigrade wire is. And you can see where the retrograde wire is, if it's gone past it, whether it's in the subintimal space or whether it's in the lumen. And obviously, if it's in the lumen, then retrogradely, you can just pass it straight into the guy cath. But if it's in the subintimal space, then you may have to do a reverse cart.
Okay.
So the way I do is I just try to connect the 2 with balloon. If it's not working, that is when I do the IVUS to find out. You're right. If they're in 2 parallel universe, then either you have to rewire it antigradely or mainly antigradely, or sometimes some people use cutting balloon and things, but it never worked for me.
Use a bigger balloon.
Bigger balloons, yeah. But yeah, John, do you have anything to comment?
Yeah, I mean, I think the use of IVUS is commendable, but it's not mandatory. I think what most operators will do is to pick a part of the CTO body where they feel it's the most likely to succeed. And normally, if you're looking in 2 orthogonal angiographic views, you're looking for the point at which the wires, the antigrade wire and the retrograde wire, are physically as close as they can be to one another.
Yeah.
And that's often a pretty good way of determining where to do your reverse cart.
I agree.
You should always try and do your reverse cart, if at all possible, within the CTO body, the original CTO body, if you saw what I mean. So occasionally when that's not possible because we're in different spaces or the wires are too far apart, sometimes you then start to extend the reverse cart outside of the CTO body. That's obviously suboptimal because you'll lose more branches than you need to. And that's perhaps useful then for that scenario to then use IVUS on your antigrade wire so that you can understand within the CTO body and try to manipulate your retrograde wire as close to the antegrade wire as you can get it whilst live on IVUS, if you see what I mean.
Yeah.
But yeah, the difficult situation tends to be when the retrograde wire is still true lumen or intimal, let's say, or plaque, intra-plaque, and the antegrade wire is extra plaque. I think that's a particularly difficult situation.